I was involved in the Bethesda system itself in the AGUS terminology in 2001, and was chair of the AGUS Guidelines Committee for ASCCP in 2001, so I have a little bit of background in AGUS. These were my disclosures you saw earlier. So our agenda today is to talk about both atypical glandular cell cytology and AIS, or adenocarcinoma in situ histology. And we're going to start out with just some general points about the cytology. This is a very uncommon pap reading. Typically in most populations it's about 0.2 to 0.3% of the total paps. And however, we have certainly had increased concerns about missing glandular disease. We're probably recognizing it more, but there also seems to be an increase in both the relative and absolute incidence of AIS and of adenocarcinoma. So we have to be concerned about glandular abnormalities for this reason and a number of others we'll talk about. Let's just talk about the categories that the Bethesda System 2001 set up. And if you use a Bethesda system in your country, they probably read them accordingly. So there is an atypical category of glandular cells that are considered not otherwise specified, and if they can't specify them any better than that, they call them atypical glandular cells, NOS, or AGC NOS. If they think they look like endocervical cells, it'll be called atypical endocervical cells, not otherwise specified. Or if it looks more like endometrial cells, atypical endometrial cells, not otherwise specified. Now, if there is a concern that these look like there might be neoplasia involved, that'll be called atypical glandular cells favor neoplasia. And it was felt in 2001 that there was now enough evidence that calling a pap adenocarcinoma in situ could be specific enough to make that a reasonable call. So in our review for the 2006 guidelines, and this is from Tom Wright's article, it showed a range in the literature of the prediction of CN2-3, AIS, and adenocarcinoma, and for these various diagnoses or interpretations, I should say, because cytology is an interpretation. You can see that the more abnormal the pap became, the more likely there would be an increased finding in these more abnormal changes. But you can see a very wide range from study to study of the reported likelihood of abnormalities. Now, Dr. Castle, who's sitting right here, along with Dr. Kinney, have provided, as you've already seen over and over again in this conference, some of the most important recent data from the Kaiser Northern California data set. And Dr. Schiffman is working on this as well now. And you can see that most of these individuals who were over the age of 30 and had co-testing, so it's 1,422 AGC PAPs, most of them actually were not found to have disease, either normal or CIN1. However, all of the categories had some risk for CN2-3 or adenocarcinoma in situ, and it's a significant risk. Certainly all of them, just looking at this, even AGC endometrial could consider going to colposcopy, although it falls below that 5% range. But you can see that all of them have a range of risk that's over 10% otherwise for high-grade squamous lesions. And then if you look at cervical cancer and endometrial cancer, although these risk levels aren't anywhere near what we saw in some of the studies just shown before this, they're very high still. And endometrial, obviously AGC endometrial has the highest risk for endometrial cancer, but you can see that AGC not otherwise specified still also has a relatively high risk for endometrial cancer. And then where it says other cancers, we're talking about typically ovarian, fallopian tube, metastatic breast cancer to the pelvis, any other kind of cancer that could be metastatic to the pelvis. So how do we manage a woman that gets these abnormalities reported? Now, the problem is that all the three methods that we traditionally use to evaluate women with AGC or adenocarcinoma in situ have specific limitations. Certainly cytology hasn't been good at picking up glandular abnormalities, and we have talked about that on a number of these sessions. Colposcopy also is not ideal for glandular abnormalities. Many adenocarcinoma in situ don't have really well-defined colposcopically identifiable findings, and sometimes can look like a normal ectopy. And this is one of the few times where I actually do random biopsies. If I have an atypical glandular smear and have any kind of glandular ectopy on the outside of the Puerto, I will sometimes take several random biopsies to be sure I'm not missing something. But typically I would agree completely with Walter, random biopsies are way overrated and probably not very helpful. Colposcopy can also miss small endocervical adenocarcinoma in situ and adenocarcinoma. And endocervical sampling, at the very best, will pick up about 50% of endocervical lesions. So none of these things are ideal. And certainly HPV testing could miss a lot of disease that's not HPV related, because this is one of the PAP abnormalities, the major one that actually you can have non-HPV associated cancers and precancers associated with it, that is endometrial, ovarian, etc. Now, age is also an important factor in terms of what you might find with an AGC PAP. As you can see from this, again, review of studies for the 2006 guidelines, that the risk of CAN2-3 and adenocarcinoma in situ for premenopausal women was in the range, you see there, 22 to 30% in the studies looked at, but for postmenopausal women it was much less. In other words, the HPV-associated lesions were more likely to be found in premenopausal women. But those that were not HPV-associated were more likely to be found in postmenopausal women. And you can see the risk of endometrial hyperplasia and cancer, endometrial cancer in premenopausal women versus postmenopausal women. Now, Zhao and Marshall Austin looked at HPV test results in histology and cytology that they had with co-testing results. And they found that detection of AIS and cervical adenocarcinoma following an AGC PAP was almost all under the age of 50. Again, the HPV-associated lesions were almost all under the age of 50 and almost all HPV positive. And you can see the sensitivity of HPV testing was high. But again, the problem is that we can't rule out non-HPV associated disease, which is particularly concentrated over the age of 40 years. And that's the problem that the authors noted there. And this was their findings. They had in their AGC PAPs, 24% were HPV positive. This is what we see in most of the studies. And you can see, at least in this study, and I think this is probably heavier weighted than what we see even in most, is that all of the CAN2-3 and cervical adenocarcinoma was found in women under the age of 50, none over 50. And for the endometrial lesions and other cancers, they were all over the age of 40, none under 40. But this is why our guidelines split out as they do, as you'll see in a minute, on somewhat of kind of an age basis from the standpoint of endometrial lesions. So because of the spectrum of neoplasia linked to these glandular pap smears, initial evaluation must include multiple testing modalities, and that should include colposcopy, endocervical evaluation and sampling, and HPV testing if you don't already have an HPV test at the time of the original PAP, that is a co-test. And we'll get to the reason for doing HPV testing as a follow-up monitor here in a minute. And then endometrial evaluation if they're higher risk for endometrial abnormality. And we should never use either repeat cytology or HPV testing as the initial triage for AGC PAPs. Unlike ASCUS PAPs, AGUS PAPs can have glandular abnormalities that are non-HPV related. So this is not a triage for the initial PAP management. So the algorithm for the initial workup women with atypical glandular cells, all subcategories except atypical endometrial cells should have colposcopy with endocervical sampling, HPV test if it wasn't done previously, endometrial sampling if they're 35 or above or have other risks for endometrial abnormality, which would be grossly obese or long-term amenorrhea. Now, why would we think about using HPV testing in follow-up of a woman that's had a colposcopy that didn't find glandular abnormality or significant disease with an Agus Pap. And this comes from Kaiser again, and this was their experience with 4,335 Agus Paps 2001 to 2004. They found 240 women that were followed for 12 months or more after an Agus Pap that was HPV negative. This was in their early days of co-testing, and had normal histology at their initial colpo, and they did not find any disease in the 12-month follow-up if they were HPV negative, any at least CN2 plus or AIS. So the guidelines as written took that into account and said that if initial Pap was Agus not otherwise specified, and this could be Agus not otherwise specified into cervical as well, and there was no CIN and no glandular neoplasia, then the further follow-up depended on whether the HPV status was known or not known. And if you couldn't do an HPV test on them, it was unknown because cytology is so poorly sensitive, the recommendation was to repeat the Pap at 6-month intervals for 4 times, which is a lot of repeat Paps, and of course it's very unlikely to get women back 4 times, but that's the recommendation. If you do have HPV results, then the further follow-up of a negative colposcopy for an Agus Pap should be, if you're HPV negative, repeat that in 12 months. Cytology and HPV-NA testing. If you are HPV positive, they should be back in 6 months for that repeat. In either case, if the Pap is abnormal or the HPV test is positive, they should go back to colposcopy. If it's negative, to routine screening. If you find any abnormality, it should be as per the management guidelines for the histology abnormality you found. And if the initial Pap was Agus favored neoplasia, this is a much greater risk Pap, as we talked about before, as well as an adenocarcinoma in situ Pap. If no invasive disease is found, even if you found CN2-3 or adenocarcinoma in situ, but no invasive disease found, a diagnostic excisional procedure should be done. And we'll talk about what kind of diagnostic excisional procedures in a minute. So the issues that increase the risk for endometrial or neoplasia are those that we've already talked about, but also if the Pap suggests endometrial origin and it's a woman who is postmenopausal, that increases risk even if it's normal endometrial cells. And abnormal endometrial cells at any age would put a woman in the situation of needing endometrial evaluation. We've already talked about the other reasons. Unexplained vaginal bleeding at any age would also be a reason for endometrial evaluation with an Agus Pap. So atypical endometrial cells or these other higher risk situations for endometrial cancer should have endometrial and endocervical sampling. A colposcopy could certainly be done at the same time, but if it's not and there's no endometrial pathology noted, then colposcopy should be done. These guidelines I don't think are changing. I think they basically, the proposal in the last consensus conference for ASCCP in September was that there was not enough information that would result in changing the Agus guidelines. So these guidelines should carry forth, even though guidelines for some of the other Pap smear abnormalities that will be reported in the literature in new guidelines in March or April will change a little bit. Now this is a survey of how well we do in the US in terms of adhering to these guideline recommendations, and you can see that they haven't been very good. 98 to 2001, only 63% of OB/GYN surveyed did colpo biopsy for Agus. And in 2004 to 2007, this was just reported to only have gone up to 76%. Now, it may have gotten a lot better since then. Comprehensive evaluation, that means going on to more evaluation if you don't find anything on colposcopy, was very low in 98 to 2001 and still under 60% in the more recent years. So we don't do very good job in evaluation. Now, one of the questions we can ask is, will HPV genotyping possibly aid in post-colposcopy management of AGC that's not otherwise specified? And we don't have guidelines on this, but certainly it does raise the question when you consider that 86% of adenocarcinomas of glandular cancers are due to 16 or 18. What would we do differently if we found they were 16 or 18 positive and we don't find disease at colposcopy? Certainly, it doesn't help us triage these women initially. This is from a study by Mulheim, which showed that when when Agus was HPV tested, 20% were HPV positive, but 8% were 16-18 positive, so it's a smaller percent. But for detection of CN2+, they found sensitivity for HPV testing was 87.5%, specificity 90%. That sensitivity dropped to 62% because you're only picking up those lesions that are due to 16-18 when you do 16-18 testing, but specificity went up to 100%. And I think what we would need to carry a lesson from this is that if we do have co-testing with 16-18 results and it's an Agus Pap, and you have a negative colposcopy, you're just going to be probably more nervous and diligent about that than you would normally, maybe more biopsies. Some people might even suggest doing a cone. I'm not ready to say that yet, but I think certainly being diligent both in colposcopy, biopsies, endocervical sampling, and further management. And just a few points on AIS, and then we'll finish up here. This is a much less common abnormality than CIN3. CIN3, there's 44 cases per 100,000, 1.25 cases of AIS per 100,000, but this has been a significant increase, six-fold since 1970. We think that the natural history of AIS to invasion is very similar to that of CIN3 to squamous cancer because there is a long lag time between the median age of finding AIS and the median age of finding adenocarcinoma. And there are indications as well that AIS increases in extent and depth just as CIN3 does prior to acquiring the capacity to invade. That is, it expands over that long period of time. The other problem is that it can be multifocal. About 10% of them are. In the US, the average age for AIS is 36 years, and this is about 10 to 18 years younger than that for adenocarcinoma. And one of the problems we have with AIS, if it's on the surface of the cervix or the portio, is it may often look pretty much like a normal ectopy. The other issue is how to treat this. This is an example of doing a LEAP where you might not be going up the canal far enough to get a multifocal lesion. So the management of women with AIS, hysterectomy is preferred, but conservative management is acceptable if future fertility is desired. And then what is done after doing a cone on these women depends on whether the margins are involved or ECC positive or the margins are negative. And if the margins are involved and you decide to, you're certainly following these women, re-excision is recommended, but reevaluation at 6 months is acceptable using a combination of cytology, HPV testing, and colposcopy with endocervical sampling. In other words, you're being very careful if you're following these women, particularly with positive margins or a positive ECC. Whereas if the margins are negative, long-term follow-up is recommended. And this is the last slide, and it's just the issue of whether we should be doing LEAPs for adenocarcinoma in situ, because these lesions can be quite a ways up the canal and be skip lesions. And you can see how the margins can certainly be involved if you do a top hat LEAP. So I agree with Walter that it's ideal to do a longer cone, either a cold knife cone or a needle cone like you were doing electrosurgical cone, or if you're really good at laser, a laser cone. Those could still have burn margins near lesions, but at least they get higher up. And this just shows you some of the data on positive margins of cold knife cone versus positive margins of LEAP. And you can see there are many, many greater positive margins noted in all these studies with LEAP. And so since following these women with positive margins is of greater concern than knowing that the margins are negative, this is certainly a complicating factor. So thank you so much for your attention. And Walter,